Welcome to the December Patient Safety Series webinar. Thank you again, everyone, for joining us. This is our December session of the series that we have co-sponsored by the NNLM South Central Region and SaferCare Texas, which was formerly known as the UNT HSC Institute for Patient Safety. We're so excited to continue bringing these expert guest speakers with the hope of empowering healthcare professionals, patients, and health information professionals to support the elimination of preventable harm and achieve the highest quality in healthcare possible. I'm so excited to announce today's speaker, Dr. Teresa Wagner. Dr. Wagner graduated with a doctorate in public health from the University of North Texas Health Science Center, where she is now an assistant professor in the School of Public Health. She is a registered and licensed dietitian and a member of the Academy of Nutrition and Dietetics and the Texas Academy of Nutrition and Dietetics, as well as holding certification in public health and as a community health worker instructor. Dr. Wagner has a passion for helping people navigate healthcare and chose to do her public health doctoral residency focusing on health literacy at the University of Texas Center for Health Communication and Literacy Coalition of Central Texas. There she received the UT School of Nursing Community and Academic Collaborative Research Award and was hired by the LCCT as Director of Health Literacy. There she worked making systematic healthcare recommendations focused on injury, illness, and readmission prevention through improved health communication. She received the Distinguished Scientist Award from the Texas Academy for her research and work in modifying the healthcare environment in Texas regarding health literacy. She currently works for SaferCare Texas as a senior fellow addressing health literacy. In that role, she has established a multi-stakeholder health literacy collaborative in conjunction with the DFW Hospital Council Foundation and testified for health literacy legislation in Texas. Her testimony helped with getting health literacy into the state health plan, and she also recently received the 2018 Health Literacy Hero Award for her efforts to develop a culture of health literacy throughout Texas. I am so pleased to tell you Dr. Wagner is actually here in the room with us this afternoon. I'm going to go ahead and pass things over to her and let her get started with her presentation. Take it away, Dr. Wagner.
Good afternoon. So today we're going to be talking about health and nutrition literacy as the social determinants of patient safety, health, and healing. So throughout the presentation, we're going to bring all of those together and bring them home so you have a better understanding on how your communication with patients actually makes an impact on whether or not they're able to get well and stay well once they leave the facility if you work in healthcare. And then if you don't work in healthcare, I'm going to be talking to you about ways that in the community we can support people in staying healthy and well through improved health communication. So in summary, then, at the completion of this seminar, you'll be able to describe health literacy and identify the issues that are related to health literacy, identify health literacy as a barrier to proper nutrition and health behavior, analyze how these impact health, healing, and patient safety, and develop solutions within your community and in partnership with the healthcare continuum. So if we start out by looking at the social determinants of health, which we know is a major impact on whether or not people are able to stay healthy and well out in the community, there's 5 facets that were spelled out by Healthy People 2020. And each of those facets, if you look, in my mind, is related in some way to health literacy. And so as we go through this presentation, I'm going to show you that relationship. So, and normally I'm in an in-person situation, but in your mind, you can raise your hand and indicate which of these you think is the strongest predictor of health status. So do you think it's income, or do you think it's literacy skills, education level, ethnic group, or people's average beer intake on the weekend, which we all know can say something about lifestyle that is actually supposed to be funny. But looking at the other factors, you can, in your mind, go, yeah, that could impact people's health status, whether it's income, education, you know, all of these things can impair whether or not we're healthy or not. So the #1 indicator is actually literacy skills. And how that plays out, we'll see in the presentation. So again, I'm usually in person, but I want you to think in your mind, whether or not people will tell you if they have trouble reading, whether or not people with limited literacy have low IQs, and the number of years of schooling is a good guide to determine literacy levels. And we all know people who got through high school without having great literacy skills because sometimes the system just sets them on a track to get out without having achieved that. And then I've also been presenting at senior citizen centers where, you know, it was a low-income area, and I was really expecting most of those attendees to have not only limited literacy but also possibly low IQs. And I had one couple was asking me some very simple questions, and another lady piped up, really elderly little lady, and she said, "There is a pamphlet inside your medication. All you have to do is take it out and read it." And I was like, wow, she blew my bias out of the water. So you can't always tell by looking at people or because of your own biases or the things that you've learned growing up, whether or not they're going to have low literacy, much less low health literacy. So that's why it's so important that we communicate in a universal precautions way, where we just assume everyone has low health literacy, and then if we need to move up in scale on what type of information we provide, then we do so. So I wanted to go through each of the different facets of the 5 social determinants of health that the Healthy People 2020 spelled out, and just kind of walk you through to look at what the breakdown is. So for health and healthcare, health literacy is actually listed there, but health literacy is also a barrier to access to healthcare and access to primary care, because if people can't read, can't navigate, my own daughter one time was trying to make an appointment with an OBGYN, and she went to their website on her phone, and they had these complex diagnoses like amenorrhea and polycystic ovary syndrome and all of the, and she hands me her phone and she goes, "You pick, I can't figure any of this out." So that just shows you that it's all interrelated. Education, same thing, language and literacy right there. But can we get through, I know we can get through some, but we can't get all the way through school and have a good education, which then, of course, is going to lead into job opportunities and socioeconomic status without having good literacy and language skills. And it starts all the way in early childhood. Social and community, to have social cohesion, civic participation, and to eliminate or reduce discrimination and incarceration, we have to have a good education. We have to have good literacy skills, because if you think about Maslow's hierarchy, we need to have those basic needs met, which we can only meet by having these basic skills in order to move up Maslow's hierarchy into doing these other things that really bring societies together and help us have good healthcare systems that people can navigate and can stay healthy and well using the advice that they're given. And then neighborhood and built environment, do they have in their neighborhoods access to foods that support healthy eating patterns? One, that's an indicator of whether or not they can be healthy, but also access to food in general is a basic need. Housing is a basic need, but what if their housing's making them sick? Crime and violence, if they don't have access to food, is that not going to perpetuate crime and violence? And then if these are also low socioeconomic areas, then the environmental conditions are likely not good as well. And then economic stability. If we look at poverty, unemployment, they probably don't have health insurance. Again, food insecurity pops up, and housing instability pops up here. So in my mind, of course, I might be a little biased because I specialize in health literacy, but in my mind, health literacy is the social determinant of health, not just part of the social determinants of health. So what is health literacy? Health literacy is defined by Healthy People 2020 and the Institute of Medicine as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Well, what's wrong with that definition? And you can see it in the left-hand corner, but when I speak to people, and actually I'm doing a study right now where I'm going and interviewing healthcare providers in different hospitals throughout North Texas. And one of the healthcare providers, when I was asking him about the health literacy of his organization, said to me, wait, stop right there. In my understanding, people have health literacy, not organizations. And so why are you asking us about our organization? And I was like, wow, so interesting that people still have that old definition in their head when we know, and a growing body of research is showing that health literacy as healthcare organizations is getting more and more important, because we've made access to healthcare and healthcare in general and navigating healthcare so difficult that we now have to reach back and help patients navigate. So thinking about it, in healthcare and health information, most of it is written at a 10th grade level or higher. But the average person in the U.S. reads at an 8th grade level, and 20% read at the 5th grade level or below. 40% of seniors read at or below the 5th grade level. 50% of African Americans and Hispanics read at or below the 5th grade reading level. And at the same time, those with the lowest reading ability are at the highest risk for health problems. So that leaves a lot of people with health problems that they don't know how to manage because they don't have the capacity to manage it, and we as healthcare are not reaching back and trying to meet them where they're at. So the key risk factors for low health literacy are the elderly, but there's also disparities with young 20-year-olds that are just leaving their parents' advocacy and having to advocate for themselves. For one, they haven't built enough skills in self-advocacy and self-efficacy, but also they are often not taken seriously by healthcare providers. And they're used to having their parents do the advocating for them. Members of minority groups, low income, people who did not graduate from high school, and non-native English speakers. So I want you at home, or wherever you happen to be, to read this passage. And again, I usually have people in person, but it's a common nursery rhyme, and when you think of it or you figure it out, if you want to type it into the chat, we'll see what we come up with. Okay, we have a partial answer. There we go. Okay, so the interesting thing about this slide is, first of all, when you first look at it, it's overwhelming looking at all those large words with all those syllables. But two, you probably don't know how to say, or haven't in a while said a lot of these words, so it might take you a minute to sound them out. So if you think about people with low health literacy, they're going to have to go word by word, letter by letter to figure this out. And therein lies the problem, because at the end of the day, or the end of the sheet, they aren't going to know what they just read. So it's up to us to provide that information in a way that is consumable and understandable by everyone. So look how simple we could actually make that. So just by using plain language or living room language, simple words, and putting pictures, we can expand the ability for people to understand the information that we've given them and make it very simple. And then the point, I guess, too, is that, you know, with people with good literacy skills, we can skim over a paragraph and get the understanding. But people with low literacy skills are not going to be able to do that, and when they walk away, they don't understand what they've just read. But two, if they're filling out a form at a healthcare establishment, they're going to quit. And they're not going to give you all the information that you need in order to make sure that the treatment that you give them is completely accurate. So when we look at different types of literacy, there's what we call basic functional literacy, which means that we have sufficient basic skills in reading and writing. Interactive health literacy, which is more advanced and requires that we have cognitive and literacy skills because we kind of have to use that information that we've just read, like on the label in the picture that the young woman is reading, to figure out, like, how much do I need to give my child? And think about if she has low literacy skills and ends up giving her child more than her child actually needs. And then lastly is critical health literacy, and that's the ability to analyze information and adapt negative external factors that might inhibit health promotion. So that would be like your doctor tells you you need to exercise more and eat more healthy. For one, that gives you no information because it's not detailed enough, but they can refer to a registered dietitian and maybe a physical therapist or a sports therapist that can help really bring that information home. But at the same time, it takes higher order thinking, and we may not have clients that are able to do that higher order thinking. So even if they have basic functional literacy skills, there's still 3 different types of skills that they need to have in order to navigate health information. And that's print literacy, is that they need to be able to read and understand text and locate and interpret information in documents. Numeracy, and that's to use quantitative information. So, for example, on medication labels where it gives you a range of ages and then tells you, you know, a half teaspoon or 3/4 teaspoon based on the age and, you know, how many hours it's been and all of these different things. And then oral literacy, which is the ability to speak and listen effectively. So if people don't have good oral literacy either, they're not going to advocate for themselves, and they're not going to have that open conversation with healthcare providers that we want them to be having, and we want our healthcare providers to be reciprocating in that conversation. So what does this mean? Well, we know, we've talked about already how literacy is a strong predictor of a person's health, but poor health literacy is also a stronger predictor of a person's health than age, income, employment status, education level, and race. The AMA, American Medical Association, estimates 90 million low health literate Americans, and AHRQ stated that 9 out of 10 Americans may lack the knowledge and skills needed to manage their health and prevent disease. So health literacy and patient safety, what does that boil down to if we know that there's that many people that have low health literacy? And even if you have high education and high understanding, when you're handed a catastrophic diagnosis, your ability to understand complex information immediately decreases. So even if you're highly educated, you can have poor health literacy if you're handed a catastrophic diagnosis, or even just trying to understand complex medical information if that's not your specialty. So when we look in the literature, low health literacy has been linked to poor outcomes, which is reduced ability to understand labels and health messages, limited ability to follow medication instructions, lower likelihood of accessing and receiving preventative care, more hospitalizations, worse overall health status, higher mortality among the elderly, shorter life expectancy, worse physical and mental health, and greater use of emergency departments. Think about if you were the parent of that baby and you gave her the wrong dose, how bad you would feel, and, you know, hopefully nothing horrible would happen to the child, but again, it's a patient safety issue. So what can be done? How do we solve this problem? Well, looking at the social determinants of health, there's a variety of ways that we can intervene in our communities in order to improve these health outcomes and the situation in terms of people knowing how to stay healthy and well. What we want to do is empower the neighborhoods that we serve. So make the healthy choice the easy choice. Bring healthy foods into those neighborhoods that are food deserts. Empower people with education that meets people where they live. And what does that mean? It means culturally, it means geographically, all of these things. So if we look at culture and literacy, we know that culture affects how people communicate, understand, and respond to health information. And a different culture may come in with a whole different set of expectations and ways that they interact with the healthcare field. So if you look at their cultural beliefs, values, language preferences, attitudes, traditions, and health practices, you really have to be open-minded in order to achieve positive health outcomes. So I have a story about Willie Ramirez, who went into an emergency department and had a brain bleed and had a really bad headache. But what he told his mom when he had gotten home before they went to the emergency department was that he was intoxicado. Well, in Cuban, that meant that he might have had food poisoning. But when they told the ER doctor that he was intoxicado, he thought he was intoxicated, so they never checked him for the brain bleed. And it ended up that he was ended up being a quadriplegic, and the hospital system had a $41 million lawsuit settlement on that case. So we need to listen, we need to get interpreters, we need to speak in a way that's culturally competent to understand people and really get to the root cause of whatever their issue is. But cultural competency and how we've looked at culture in the past is we've kind of memorized a set of cultural tenets that we thought were assigned to different groups. And really now we know, different groups are mixing their cultures, but also that we can't understand every nuance about where someone grew up and what their social determinants of health are. So instead, we want to start using cultural humility. And what cultural humility is an openness to look at yourself. So really accurately assess yourself and what your own biases and your own limitations are in understanding other people. And really taking in the information of where they're at and trying to apply whatever the advice is that you're going to be giving them, or you're going to be working with them on a mutually acceptable solution to help with their health problem. You have to embrace gaps in your own knowledge, so be willing to understand that you aren't necessarily the be-all to end-all. You are a tool that can help people achieve good health, but only if you are willing to work with where they are at. And in order to achieve that, you have to have openness to new ideas. So when I lived in Austin, and if any of you live in Austin right now and or have visited Austin, you know about Amy's Ice Cream. So one day I was sitting in Amy's Ice Cream enjoying my ice cream, and I hear a cat meow, and I was like, okay, I'm the only one in there except for this one woman that had just walked in, and hear this cat meow. I'm like, does she have a cat with her? So I look and don't see a cat, and she walks up to the counter and starts meowing her order with, paws up to the guy behind the counter, and the whole time he engages with her and meows back at her and gets her whole order filled, and she is happy and is walking out, and he yells back to her, paws up, which I guess means have a great day. But I thought to myself, now that is cultural humility. He was willing to meet her where she was at and provide service. And I think us as healthcare providers need to use that same lens. Information and cultural competency. So we know that if we aren't culturally competent, if we don't provide information where people are, it can actually disable people. It must be accessible and relevant. I did a study recently on websites for seniors and found that only 5% of the websites that I looked at had reading levels and font sizes that were senior-friendly. They have to support autonomy and decision-making, so make it simple enough to where people can make informed decisions. That's part of the whole health literacy definition. Providers must be willing to listen and hear. So my daughter, when she was in her early 20s and in college, was having problems with a health issue and kept going to her provider and telling them that she was constipated, but she knew that there was more to it than that. And they were like, oh, no, you're just constipated, and they wouldn't listen to her because, I don't know if it was her age or whatever, but they wouldn't listen to her. And I kept telling her, no, you have to go back, and I kept making more appointments, and they kept sending her home telling her the same thing, and it wasn't helping. She wasn't becoming unconstipated. So finally, 2 months later, she went in and for an MRI finally, and was fasting for that MRI, left the appointment, and was about to take a bite of a donut, and they said, you need to get back here immediately. We need to do emergency surgery for appendicitis. She could have died, and all because the providers wouldn't take her seriously. So we have to, it's a patient safety issue. We have to listen and hear and be willing to take in that information, no matter who it is that we're working with. It has to be, we have to give information that's person-centered, and we have to give care that's person-centered, and share knowledge and information in a health-literate manner. Otherwise, the information and the services we're giving disable, discriminate, and apply barriers. And that's where the culturally and linguistically appropriate services standards for healthcare came from. I know Texas has adopted these, not all states have, but the CLAS standards address improved quality of care, access to care, and elevate patient health outcomes by providing effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. And then if we are the healthcare provider, we need to document that we're doing that. So this was a study that was done in a culturally and linguistically diverse community, and it was focused on Arabic, Chinese, Italian, and Spanish, and looked at what their information sources were, their access to information, and the information that was provided. And the needs that were identified fall right in line with everything I've been saying, is that there's a more strategic and coordinated approach that needs to be developed, greater emphasis on supporting and enhancing the interpersonal aspects of information provision, greater range of information for culturally and linguistically diverse communities, and ensure that information, resources, and processes reflect the circumstances and needs of these communities. So it's not one size fits all. We can't just do plain language and 5th grade level and think it's going to meet the needs of everybody. So this is my little graph that I made in terms of if people have limited English proficiency and therefore inability to communicate well or at all in English, basically it severely limits their access to health information and health services. But it's not just language. There are a lot of people who don't have the education or the ability, the exposure to healthcare to understand health information, or they have some type of impairment understanding health information, and that could actually be mental health issues. But this also impedes their ability to absorb health information and access health services. So what we need to do then is to communicate plainly in primary languages and use words and examples like Little Miss Muffet to make information more understandable. So then we complete the triangle and make health information and health services more accessible and understandable. So here's kind of the model of the journey of health and well-being that, in my mind, I actually took this from a resource, but you know, we collect health information from all these sources. We get it from radio, family, friends, but we have to then use our cognitive brain to assimilate all that, and we have to integrate that with what our family health history is, our ethnicity, our culture, and then what are our social activities? What do our friends do? Do our friends encourage us to eat healthy? Do we exercise as part of our hobbies? Do we have the money, work, and community where we can actually get out and do those things? When I worked for early childhood intervention and I would be talking to mothers about, you know, getting out and taking a walk, I had to be cognitive of the communities that they lived in and whether or not that was safe or not. And sometimes they would call me and go, oh, don't come today, we just had a drive-by shooting. So not all communities are conducive to the lifestyle that we need to be living to have health and well-being. So that brings us to how do we learn about nutrition? Because when we talk about lifestyle, yes, it's good to be active, but probably even more importantly or equally importantly is good nutrition. So if you look at nutrition information for disparate populations, it becomes a part of health literacy, because how do we learn about good nutrition and how do we relate that to our own health? There's a whole couple of generations who kind of go, oh, I have diabetes, and oh, but I don't relate that to the fact that I lay on the sofa and watch TV all day, that it's exacerbated. So we kind of have to connect that and really start with K through 12, which is my recommendation for legislation. But we really have to look at the communities that people are brought up in to see if it's conducive to building that foundation of knowing about good nutrition. So a comprehensive conceptualization of nutrition literacy is needed that incorporates key elements of health literacy and food literacy constructs. Otherwise, people don't understand the importance of having that nutritional foundation, and they go for what tastes good, what's easy, what's available in their neighborhood. One time I was driving to go do a talk in rural Michigan, and had to go like into farmland and all of that, and I got hungry because I'd just been on a flight and had to drive 2 hours, and I started looking for some place to eat, and sure enough, the only thing I could find was fast food, and I was like, oh my God, this is real. So it does happen, and so we call these food deserts. A food desert is a low-income area or neighborhood. It could be also a rural area that lacks a proper source of healthy food. These areas usually have many fast food chains and smaller convenience stores. But how do you learn about healthy nutrition in this environment? So who is affected? People, in terms of not being able to empower people to stay healthy and well when they don't have access to healthy food. Again, it's the people who live in food deserts that have low income and no transportation, and children who grow up eating unhealthy food as a result. So if you look at the U.S. as a whole, this is a map that shows where those food deserts lie, where people have either no car and or no supermarket store within a mile. And you can see there's a lot in the south, that's where the really high prevalence is, but also in rural areas throughout the country. And that's where we see these big pockets of these degenerative diseases or chronic diseases that need to be managed well, but yet these people tend to have low health literacy. And then advertisers get in on that. I mean, not that they're targeting to make people unhealthy, but if you only have access to McDonald's, and then it's set up as, oh, this is where we can have a nice family dinner, and I'm not criticizing McDonald's in any way. I think they have made great efforts to have healthier foods. But if you look in the picture, there are like 2 sundaes and sitting in front of the girl. There's a coffee drink that has a lot of sugar. It does have milk, but it also has a lot of sugar. Fried foods, and then another sundae, sodas. Really very little nutritional value, despite the fact that it is a nice family meal. We just need to change the foods that are being served. So the health issues are that people who live in food deserts may eventually develop health issues such as obesity, cardiovascular disease, cancer, diabetes, and have premature death. So are we looking at superheroes of the future looking like this? I don't know. But what can we do? So from the healthcare perspective, I'm doing a study right now on, as I mentioned, where I'm interviewing healthcare facilities and talking to, because of the collaborative I've built here in the North Texas area, I'm able to talk to CEOs and to CNOs and other leaders in the healthcare field, which has been very hard to establish in the past. Generally, the people working on health literacy are those people that are in direct patient care and have no power to change, despite the fact that they're frustrated by the inability of their time or the system to give the people good information that's going to help them stay healthy and well when they get home. So if we look at the IOM attributes of a health literate organization, the most important is that we have leadership that promotes health literacy and good education, which means it needs to be embedded in the mission, vision, or at least the strategic plan, because that's where we're finding, at least in my experience, when those leaders that are advocates of health literacy leave, the person whose job is health literacy inevitably gets fired or moves to another department where health literacy is very minimized. So they also need to plan, evaluate, and improve their health literacy, so they should be looking at patient outcomes in relation to health literacy and patient safety in relation to health literacy in terms of medications, all of these things. Prepares the workforce, so they need to train the staff, the nursing staff, the front staff. I mean, I once had one of my focus group patients tell me how rude the front desk staff was to her. It made her never want to come back. And so then we wonder why people don't follow up, and we label them non-compliant. We also need to ensure that they have easy access, so patient navigators or some type of assistance with insurance. Also that we are communicating effectively, which is basically my whole talk. Explains coverage and costs, and that's one thing that we don't do well in the healthcare system today. And one of my colleagues who, you know, is a nurse and makes a good salary at one of the facilities that we interviewed, and said, you know, there's times when I don't go, even though I have something wrong, because I have no idea what it's going to cost me, and I'm afraid of what it's going to cost me. And I was like, I do the same thing. So think about people who have no money and no understanding what that's doing to them wanting to actually access healthcare and or preventative services. We need to target high-risk populations and make sure that we have good informed consent if we're having to rip somebody's appendix out or do an emergency C-section, any of those things, making sure that people understand the procedures that they're agreeing to. Design easy-to-use materials, and I think that's one of the hardest things to achieve in large healthcare systems, and any doctor's office for that matter, because there's so many materials, and to have someone on staff that actually keeps on top of that and has the skills to produce health literate information. I know there's a huge need in that area because there's not a lot of people that are trained in health literacy. We need to meet the needs of all, so making sure that we have good cultural competency, that we have people that interpret, all of these things that make healthcare welcoming, and then also include consumers. And this is probably the one thing that we do, well, I won't say the one thing because a lot of things we're not doing well, but we tend to not include people and ask them, you know, are you able to understand this? And if not, how could we make it better, and what would be the need to know for you? Because a lot of times we give all this extra information, which is not need to know, and all it does is water down and or discourage people from using the information that we need them to use. So one of the studies I'm doing right now is on maternal mortality. And after weeding through the information that we got from different hospital systems to kind of boil it down to need to know, our next step is to actually go out and interview people that are recently postpartum and say, what of this do you understand? What would have been useful for you? Was it culturally competent? All of these things, so that we can make these directions more usable and hopefully lower the maternal mortality rate in the state of Texas, if not the country. So thinking outside of healthcare, if you look at this chart, actually clinical care is only 20% of health outcomes, and all of the social determinants of health that we've talked about really play a larger role. And so we need to be able to reach out into the communities and either work with what we have to make it better and or bring programs out that can help make things better. And you think, you know, physical environment, what can I do about that? I once did a program in Austin where we partnered with a housing authority that, and then also service that went in-home I think it was Meals on Wheels, and we would have the Meals on Wheels people, if they saw unsafe things in the homes or asbestos or lead paint or all of these different factors, they would let us know, and we would work with the housing program to come out and remove those factors. So really having to look at the social determinants of health, and some of the suggested solutions is bringing information out into the communities. So partnering with these home-based services like Meals on Wheels, visiting nurses, home health, early childhood intervention, which I worked for at one point. Promoting the Healthy Communities is a program of the Public Library Association and the National Network of Library Medicine. And for example, in my mom's little town, Georgetown, they have a WOW mobile that brings information out to seniors that are homebound and even young people who can't get out into the library. Also using e-health literacy interventions targeted at vulnerable populations that bring computers to populations that don't have computers and teaches them how to access information. Now we just got to get all the information that's out there that's credible into a health literate format. It's a big job. We got a lot to do in health literacy, but we can also use recreation centers as a way to get health information out. Community groups such as churches have free health fairs, have mobile health care. So in Austin, I worked with a dental bus that went out into communities. Here at UNT Health Science Center, we have the pediatric bus that goes out and does medical care for children out in disparate communities. Promotoras and community health workers. In my opinion, these people are the conduit of health literacy. They go out into the neighborhoods and they speak the language and they know the customs and they know the culture, so they can carry those health messages out into the community. And then workplace wellness programs make where we work a healthy place as well, because in my opinion, the work hours and culture of the U.S. is not conducive to good health. So nutrition solutions. Obesity is actually very expensive, so why don't we reinvest those costs in getting people healthier by providing healthy food access? So these are a couple of examples of the healthy foods. I kind of wanted to redeem myself with McDonald's. But, you know, oatmeal and then fruit and yogurt parfaits, which come in really handy if you're in the airport and you need to grab a snack. I do that all the time. Keep pushing fast food to evolve, I guess should have been, and offer better options. Education on healthy eating and food preparation out in the communities and through these venues as well. Have the market do well by doing good. So Walgreens has an initiative to turn 1,000 locations into food oases. So if they're in a food desert area, offer healthy foods in their stores. Healthy food financing initiative, incentivize stores to open in food deserts through tax credits, below market pricing, and guaranteed loans. And then raise and enforce SNAP standards, because we know there's a lot of unhealthy foods that SNAP dollars can go towards that they really shouldn't be. They should be going towards healthier foods. Bring nutrition out into the community. You can see the pictures here of mobile options. We actually can do delivery, vending machines at work. But also connecting with farmers that produce fruits and vegetables for people who live in food deserts through green carts and community gardens. And then foundational support and microfinance. So even the government can get involved. In New York City has probably been one of the entrepreneurs in terms of promoting health through government support. But they have food retail expansion to support health in their city and state. Also, there's a Healthy Corners program in DC, and then also, you know, putting pressure on SNAP to include farmers markets, because they often don't count as a venue, whereas they could buy fruits and vegetables there, and liquor stores do count. It doesn't make sense. So this study just showed that if you give parents understandable knowledge about nutrition, that they'll want more, that they really do want to know. We just have to put it in a way that they understand, that's culturally applicable to them, and we meet them where they're at. And then lastly, potential health literacy legislation, which I always push for. despite the fact that health literacy is now in the Texas State Health Plan, I would love to see us have it mandated in K through 12 education, because how else are we going to raise the next generation of people who do understand and do link their lifestyle to whether or not they have adult onset diabetes or high blood pressure, preeclampsia, all of these things that are negative outcomes. Allocate funding for health literacy issues. That was one of my big concerns when I started health literacy work in Texas, is I saw all this need, and all of these, especially rural hospitals, came to me and were like, yeah, we really need your help. And I was like, yeah, but I got to get paid. So I'm hoping that in some way we can start really bolstering funding for health literacy issues, because it is important. And actually, if we just took the money off the back end from all of the poor outcomes and put it on the front end to improve health literacy, we could improve health across the state and the country. And then promote health literate communication and facilitating legislation to support infrastructure in services, health and wellness, reduce degenerative and chronic diseases, and training our healthcare providers to use health literate practices coming up, and then also continuing education for providers who are already in practice. So in summary, as I said, in my mind, health literacy is the social determinant of health, but it interacts with all of these things that we've talked about today: the healthcare system, culture, society, and access to health, and education, and all of that boils down to healthcare outcomes and costs, which we all want to improve, and we all want to lower costs. So I now will take your questions.
Great. Thank you so much, Dr. Wagner. I want to remind everyone you can put your comments into the chat box. Your questions, will be sharing them with Dr. Wagner here. We did have a question come in earlier. Let me answer this one really quickly. The slides are available. We'll have our support person put the link in the chat box once again for those. But the question that came in earlier was about why are the elderly so predisposed to lower health literacy levels?
So a lot of reasons, but I guess if you want to just look at elderly in general, as we age, our ability for cognitive efforts decreases, our dexterity decreases, and our vision decreases. So all of those things put the elderly at more risk. And I mean, I just know from my parents and my friends' parents who are in their 70s and 80s now, that things progress, and the way we give medications, the way we interact with the healthcare system, all of these things are now technology that they don't understand or haven't grasped. And then on top of that, when we put information out there that's not health literate, that even compounds the problem more, like I talked about with my study on the websites and the font size and the readability.
Mm-hmm. Yeah, a lot of issues facing that elderly population in particular. Great question. Any other questions, go ahead and please put them into the chat box. We will also go ahead and share Dr. Wagner's contact information. I'm sure she'd be happy to answer any questions if anyone has them at a later time. We'll give a couple more minutes in case anyone is typing out their questions now. All right, we have another great question that's come in. With so many obstacles, transportation, access, cost, demographics, etc., how can librarians be of the most help? As a health science librarian at a medical university, I see so much disparity, but I want to do more than just research. So how can non-clinicians help? I do think Dr. Wagner had a little bit about that on a previous slide, but maybe you can give us some more ideas.
Yeah, so definitely reaching out to community organizations and partnering out in the community to help provide services. As a librarian, you are a huge, rich resource of health information. So really looking out, I just did a health literacy needs assessment for North Texas in collaboration with my DFW Hospital Council group. And really we looked at those things, and it's all about what programs are out there to reach these people that are not able to reach out for themselves. So the more we can do to get that information out into the communities, like I said, where they're at, then definitely need to do that. And I'd love to help brainstorm with you and possibly, you know, connect you in your area.
And I can say certainly here at the South Central Region Office, it's one of the reasons we're so excited to partner with SaferCare Texas, because they are doing programs like this, and in any way that we can help them with our funding, with our knowledge and all of that is a really great opportunity for us as well. Here I have another question, someone who's familiar with cultural competency and also a TCOM health literacy conference. Do you know if there's anything like that planned in the near future?
So we used to have a health literacy conference here at UNT Health Science Center. We haven't had one in a few years, but there is a really great one that the Health Collaborative down in San Antonio puts on in October. It's usually the first weekend in October every year. That would be a good resource for you. Hopefully at some point we can have a TCOM health literacy conference, but right now San Antonio is doing a really great job at it, and I wouldn't, necessarily want to compete with their efforts. In fact, we are starting to build a collaboration with them, so hopefully this will be a Texas-wide and nationwide effort.
Great.
And there actually, too, I want to add is we just formed, so I'm connected with other health literacy professionals throughout the country, but we've just formed an international health literacy association. So our goal is to really tackle these issues from a global perspective. So if you're interested in joining that and then also learning about some of the other organizations that are available nationwide, feel free to reach out and I'll help you get connected.
Great. And do you have the name of that San Antonio program off the top of your head?
So they're called the Health Collaborative. It's where I got the award from. But they also call their health literacy program is called the San Antonio Health Literacy Initiative. So I'm not sure which website you would go to, but you can try both of those.
Great. I have another question here. You mentioned SNAP. What's your experience with WIC, especially in rural areas, maybe with Native American populations? Looks like farmers market vouchers through WIC can work if clients go to get them.
Great. So yes, so my experience with WIC is that they do a great job of really limiting the foods that people can get, and I don't mean limiting them to because they still embrace culture and all of that, but limiting the unhealthy foods people can get. And if they make them usable at farmers markets, then definitely that's a great program.
Great, and we're having a lot of, I like this, someone said it's not limiting, it's guiding.
Yes, thank you.
And we have a lot of people sharing in the chat other resources for health literacy. Thank you so much. I do know that University of Arkansas for Medical Sciences has a Center for Health Literacy as well. And if you're part of a med school, you can work with students in the community when they do outreach and clinics to do setup and share information. Yeah, we do have the Medline Plus English and Spanish resources. That's great. All right. Well, if there's no other questions at this time, I will go ahead and encourage everyone to write down Dr. Wagner's contact information if you do think of a question at a later time, but I'll go ahead and thank her for a fabulous presentation before we finish up our recording and do our final housekeeping. So thank you so much for being with us here today, Dr. Wagner.
Thank you.
All right, I'll go ahead and stop the recording now. I do ask if everyone would stay logged on for just a couple more minutes as we do our final housekeeping.